everyone. My name is Alexandria. I am the Associate Director of Operations at the Center for Global Women's Health Technologies. And we're going to go ahead and get started. First of all, thank you so much for joining us for this lunchtime talk. For now, feel free to go ahead and keep your video on or off, as Ashley just said. We'll be keeping everyone on mute for the first portion of this call, but feel free to communicate with us in the chat. So today we'll be talking about the Black maternal health crisis. According to a 2020 study, American women die in childbirth at a higher rate than in any developed country. Non-Hispanic Black women are more than 3 times more likely to have a maternal death than white women in the United States. So today we are joined by 2 incredible speakers who will share their unique experiences, and together we will have a conversation about how we can make changes to improve the quality of life for Black mothers and their children. Our 2 panelist speakers today are Arielle Hutchinson, a Duke University student, and Maya Jackson, a trained doula and the founder and executive director of Mobilizing African American Mothers Through Empowerment, and it's known as MAAME Incorporated. I'm going to hand it back over to Ashley now for further introductions.
I was muted there. Hey everyone, I'm Ashley. So Alexandria and I, you've heard us talking already. We will be moderating the chat. We both work at the Center for Global Women's Health Technologies at Duke. She is the Director of Operations and I'm our communications specialist. So we focus more on the educational mission of our center, which I will share just a little bit more about before we get started. So our center was founded in 2013. And we have the mission of empowering trainees to create impactful solutions to improve the lives of women and girls globally. This center, since inception, has catalyzed new research activities and the development and commercialization of several technologies that advance prevention in the treatment of breast and cervical cancer. We're working together to advance our center's mission of erasing disparities in women's health. While the majority of the staff come from an engineering background, Alexandria and I, like I said, have the opportunity to focus more on the social and community engagement aspect of our mission. So that's kind of what we're doing here today. Over the summer, we curated a blog series that addresses inequities in women's health, spanning from the origins of gynecology to today and dealing with everything from personal stories to a hard look at the data. This panel is based on a blog written by Arielle over the summer. So with that, I'm going to kick it off to Arielle to share, and then we'll hear from both of our presenters and move into a time of Q&A. So Arielle, thank you so much for being here today. I'm gonna let you take the floor.
Thank you so much for having me today. And so first, I want to start off with how I got interested in this issue. And so my mom is a doctor and anesthesiologist, and growing up, dinner time was always filled with the latest hospital news. Sometimes I'd hear really cool stories about people getting brain tumors removed and regaining part of their vision, or cutting edge experimental surgery. But I've also heard my fair share of horror stories. The first maternal mortality case I heard when I was younger was when I was maybe 14 or 15 years old. And it was one from a while back, and it happened years ago when my mom was working in the heart of New York City. One night, a 19-year-old came in to have her baby, and she was a Haitian immigrant who spoke French, but very little English, and she had no health insurance and no prenatal care. With the odds stacked against her, her pre-existing medical conditions untreated, and the language barrier, it was no surprise that her delivery resulted in disaster. During delivery, her doctors missed key warning signs, and at the last minute, they opened her up in her hospital bed, and she bled to death at 19 years old. The story that hits me the hardest, though, happened in December in my small town in New Jersey at the hospital my mom works at. Over winter break, my mom shared one of her colleagues' experience working on call, and the story goes something like this. A woman in perfect health came in to have her baby. At first, things were going pretty well up until the point the baby went into distress. Somehow, yet again, the signs were not detected until the very last second, and the doctor made the decision to cut her open without anesthesia. And her screams echoed throughout the OR. And to this day, my mom's colleagues still has nightmares about those screams. And I just can't help but wonder if they still would have cut her open without anesthesia if she was white. These are just 2 stories of hundreds. What my mom told me isn't specific to her local community or even New York or even New Jersey. It's a nationwide problem. As of 2019, the CDC reported that Black women are 2 to 3 times more likely to die from childbirth or pregnancy-related complications than white women. And you have to wonder why. That's a pretty significant number. Some people might think, oh, there must be something wrong with Black women. Why are these numbers so high? And at first glance, some variables like prior health issues, low income, and poor access to healthcare come to mind. And all these factors do play a significant role in health outcomes. However, there's another factor that remains constant throughout every case, and that's race. Nina Martin, a journalist, decided to investigate what exactly was driving up the maternal mortality rate, and what she found was disturbing. She discovered that neither education level nor income level affected Black women's health outcomes. Essentially, when you look at the number of Black women who have died, the numbers remain the same across all income and all education levels. She also found that Black women with college degrees suffered even more severe pregnancy-related complications than a white woman who had never even graduated high school. This goes to show you that maternal mortality doesn't care how much money you have, how well educated you are, or how much access to healthcare you have. It just cares that you're Black. So for a famous example, let's take a look at Serena Williams. She is one of the greatest players of all times. She's healthy, wealthy, and has access to many resources that the average person doesn't. In 2017, she gave birth to her daughter, Olympia, but what was supposed to be one of the happiest moments of her life was almost ruined by dismissive doctors. After having a C-section, she immediately complained of having trouble breathing and thought she was having another pulmonary embolism, which is because she had one in 2011. And she told the nurse how she was feeling and asked for a CT scan. And the nurse didn't take her seriously and actually thought that her pain meds were making her confused. Turns out she did have blood clots in her lungs, and she was given the proper treatment in time. However, the excessive coughing from the embolism caused her C-section wound to open and led to even more surgery. And that's how Serena spent the first 6 weeks of motherhood in bed recovering. Serena saved her own life. She was her own advocate, even when those around her refused to listen. Imagine what would have happened if she hadn't spoken up. And even when she did speak up first, did the doctors listen? No. So really, she got lucky that someone decided to pay attention before it was too late. If someone as famous and wealthy as Serena Williams was ignored by her doctors, I can't help but wonder what will happen to the rest of us. Whether we want to admit it or not, the color of your skin can sometimes impact the quality of care that you receive. And you don't need to be racist to have implicit biases or believe in stereotypes. For example, researchers at the University of Virginia quizzed white medical students and residents to see how many of them believed in Black stereotypes. And some of the stereotypes include things like Black people have less sensitive nerve endings or thicker skin or blood that clots faster. Half the doctors surveyed thought that at least one of the false statements presented was definitely true or somewhat true. And those who believed in the stereotypes often rated Black patients' pain lower than white patients' pain. And they also made less appropriate recommendations about how those Black patients should be treated. And this is just one example of how skin color can affect health outcomes. In the US, most maternal mortality deaths are preventable. According to the CDC, 60% of women who have died could have been saved if they had better access to healthcare providers. And today, those death rates continue to rise. The United States has the highest maternal mortality rate out of other similarly developed and high-income countries. And again, you have to wonder why. And the US maternal mortality rate is mainly elevated because of the disproportionate number of Black deaths. Black women are only 13% of the female population, and yet they account for 40% of the maternal deaths in this country. And when I look at these numbers, I just think that it could have been my mom or my aunt or my cousin. And I think it could be my sister, my best friend, or even me in the future. And I don't want any of us to become another statistic. In our country, Black death is already normalized. All forms of Black death are already overlooked. So it's easy just to sweep Black maternal mortality under the rug, like everything else. But giving birth shouldn't be a death sentence. Survival is the bare minimum. Birth shouldn't just be safe, but it should also be supportive and empowering. It should be the polar opposite of what my mom recalled through her years of medicine. But through more intentionality in part of medical professionals and society as a whole, Black maternal care can be enhanced to give Black women a better chance at becoming mothers. Thank you.
Great. Thank you so much, Arielle, for sharing. We'll hear from you a little bit more later during the Q&A section. But for now, I'm going to go ahead and pass it over to Maya to share.
1 second to pull up our presentation. Can I screen share from here directly? Okay, great, thank you. So hi, my name is Maya Jackson. I am the founder and the executive director of MAAME Inc. We are a community-based doula program based in Durham, North Carolina, but we also serve the Triangle and surrounding areas. All of the stats that Arielle had mentioned are so true. They are my own personal lived experiences as a Black birthing person in this country. My first birth experience, the pregnancy was beautiful. I loved everything that was happening with my body. I researched and had a birth plan and felt like I articulated everything that I wanted for my birthing experience and provider. But by the time I got to my second prenatal visit, my provider was ready to schedule me for a C-section. And at the hospital when I was in labor, I could hear the nurses gossiping about me on the floor while laboring. I think at the hospital that I was at, it could have been a teaching hospital, and may have had some nurses who had never seen someone naturally labor and birth for as long as I did. And so, my birth was pretty much a spectacle, and my body was on display while I was at the hospital. I remember telling the nurses that I did not want any students in the room while laboring. And when I was in fully transitional labor, as I was pushing my daughter, I just remember seeing like a bunch of white coats in the room as I was naked and pushing out. And so I completely lost focus. I was exhausted. I had been birthing for over 16 hours at that point in time. And I felt like I was just going to give up. I just felt like I was going to die in that experience because I just did not have the momentum to just keep going after that happened. Then I had my daughter. It was a beautiful experience, just being able to hold her after that. But then that is where the neglect kicked in. The nurse that was on care on that shift that was supposed to be caring for me forgot to massage my fundus. And for people who don't know what that is, your fundus is your uterus. Is you massage it to make sure that you're reducing any amount of postpartum hemorrhaging after birth. And probably within hours after having my daughter, I could just hear like this gush coming from my body. And at that time, I didn't know what it was. All I could think was just to hit the nurse call button and say like, hey, I think I had an accident. And she just casually comes in and she's like, oh my gosh, I forgot to massage your uterus, as if it wasn't a big deal. But I was actually bleeding out after I had my daughter. And that was like the first sign for me to be like, there's something wrong with the system. Not only was something wrong in the system with how providers saw me in that space, but I also had my daughter in the beginning of the recession, the 2008 recession. And so it was just very hard for all Americans, no matter what background you were. But if you were a person of color, it was extremely hard because the system is not built for us. So I went into institutions trying to get support and services for me and my daughter. And there was no amount of human decency that they saw that I was worthy of receiving. And so my care throughout that experience was subpar. I was treated as if I was not a competent person to think on my own or to be able to ask questions to make an informed decision. And it just really opened up my mind that for someone who's college educated and Black that's going through this, what is someone who is not college educated and Black that is going through this? Because at least I know how to advocate for myself. I know how to go down different channels if I need to get additional support. But that just really just opened my mind to just how messed up the system was. After that, I decided that if I was ever to become pregnant again, that I was going to change my focus on dealing with a traditional doctor and then going with a midwife, which was great. But I was so traumatized from the hospital experience the first time around. Thank God my second birth was really fast because I wasn't there long. But I said, okay, if I'm going to do this again, if I ever decide to do this again, I'm going to go with a midwife. And so I'm a mom of 4. My last 2 births were the most empowering, life-changing birthing experience that I've ever had. I birthed with the midwives at a birthing center, and I hired a doula. And I did not realize how much support I needed in that moment while laboring, but also the people in the room with me, because your midwife in a birthing center, you can have family there. So it's not a bunch of machines. It's not a cold space. You can eat. You're pretty much operating as if you were at home. Or how much support my partner needed during that time. It was just very life-changing. It felt like what community was supposed to be, how it was in the past when someone was laboring. And I was inspired to become a doula. And so I became a doula through a rural health program in Alamance, North Carolina. And it was a phenomenal program. You know, the way that public health has been structured in this country has greatly impacted the rural community as well. But I think a lot of times people assume that if you're living in an urban environment with institutions and systems, then healthcare must be great. And it's not. Living in the Triangle, there's so many inequities when it comes to healthcare. Durham is a great case study of that. A great number of women that live in this community and across the state don't have access to health insurance because our state has not expanded Medicaid. Half of the women in the state of North Carolina are uninsured. And so when you think about the amount of access in that window of time that someone can have to receive prenatal care, evidence is showing us that most women in North Carolina who are on Medicaid aren't receiving care until about the end of their second trimester. And that is a big gap. That is a big gap of time being lost on doing early intervention, genetic testing, just overall, just education. And that is one of the pieces that I notice a lot with the clients that I work with, is that education piece. If they would have had it earlier on in the beginning of the pregnancy, it would have helped produce better health outcomes after childbirth. And so I just wanted to show you guys and kind of go through what our organization does. We started in December 2018, and we trained thus far 20 Black and Brown doulas. These ladies are mothers, they are aunts, they are all within the community that they live in, that they serve. We are family oriented, so we encourage all of our moms to bring their children with them. I take my kids everywhere. You know, I let people know that if you want me to be in a meeting with you, 9 times out of 10, I'm going to at least have one of them there, and that is going to be okay, because I want to normalize that a mom can work and be efficient at working while her child is in the room with her. And so I did not want childcare to be another barrier that we put on our families to prevent them from having access to gaining new skills that they can take to the community. So we provide perinatal case management, which is a mixture of full spectrum doula services, postpartum, birth, for up to 18 months. We make sure that all of our families that come through our program have a produce box at the end of pregnancy, because we want to make sure they have a good, healthy start once they come home. We also give transportation vouchers. Durham, where we live, is not a transportation-friendly community. So we have a lot of families here who don't have access to get to their medical appointments, let alone to get to the hospital. And it makes it very difficult, because when you're an agency such as myself that's very small, we don't have that liability to be able to pick people up. And so we're having to coordinate transportation or call EMS to be able to pick these families up from their home to safely transport them to the hospital. We also encourage breastfeeding breastfeeding through breastfeeding peer support, child education classes, and tons of community resources. And last year in 2020, before COVID hit, we were dealing with a major housing crisis here in Durham with a lot of families in the MacDougall Terrace community. That community had 3 Black infants that had died before February of 2020. Now, the coroners would like to say that they don't know why these babies, just died unexpectedly. But when you think about the social determinants of health, you think about the environment that those children had to live in, the infrastructure in those homes had led constant pipes bursting, mold, all of these things that contributed into, I personally believe, the deaths of these young babies. Because now, even though lead has typically been a thing in the past, if you look at certain zip codes in Durham, North Carolina alone, you'll see which communities are still impacted by something that should have been eradicated a long time ago. And it's because that housing community was built in the 1950s and has never been remodeled or revamped in a way to ensure that these negative health outcomes don't happen again. And so for those who don't know what a doula is, and maybe there are tons of people here, we provide emotional support, information, and physical support. I also like to say that we are advocates. We are advocates in empowering our clients to find agency in themselves, to advocate for themselves, whether it be in a medical space, whether it be in a space with teachers, in any room where you feel that you need to have a voice to advocate for yourself. It's our goal to provide our clients with that information so they feel confident in knowing what's happening with their bodies and their lives. And so we believe in providing evidence-based information. And so we do a lot of evidence-based training. This photo that you see right here is from our OR training that we've done with UNC Birth Partners, because we want to make sure that when our families are in the event that they have to have a C-section, that we're still able to be in the room to provide support with them along the way. We're also, like I said, firm believers in making sure that our clients know how to advocate themselves with medical providers. So we provide the Black Coalition for Safe Motherhood training, which was designed by an OB, Dr. Leslie Farrington. And it really helps our families know what questions to ask, in what spaces, what loopholes are available, just really knowing what their rights are as consumers, because a lot of times we remove the fact that people are consumers in healthcare. A lot of times we're told that the doctor is the doctor and you just kind of do what they say, but people don't know that they have a choice and that they have rights. And so we really like to make sure that our families know how to do that. With COVID, a classic example, a lot of our clients had providers that they did not like working with, and we could tell that mommy's on a call. Let me finish. We could tell that they were having issues with white coat syndrome and some other medical related complications early in their pregnancy, because their blood pressure was going up. And so I would teach them how to go and through their a My Chart or Epic, whatever program platform was available, to say hey, you can go in here and change provider. You don't have to keep seeing the same provider if you don't want to. Yes, you can. You could also, sorry, he was just throwing me off. Okay, one second. Please close the door. Thank you. I got it. It's okay. Thank you. But yeah, just making sure that they understand that if they see something on their medical charts, right? If you see something on your medical chart that is incorrect, that you have the right to change it. Doctors, providers aren't great at everything. Sometimes they make mistakes. Sometimes they'll place things intentionally that is incorrect in your charts. So we try to make sure that our clients are fully aware of how to navigate these systems and to make sure that they can adequately represent themselves in a way that they feel that they are being heard and respected. We also are like super big on reclaiming birthways. So, you know, we've talked about like the systematic structures with healthcare, as well as with some of the social services and other agencies that are supposed to help people. But a lot of the things that we used to do as communities of color were stripped from us. Our birthing practices were stripped from us. They were prepackaged and sold so that way people could commodify off of in a way, and build businesses off of. And what that has done for a lot of communities of color has created shame. So for me, I am 5 generations of Durham, being in Durham, North Carolina. My family has been here since the 30s. My grandmother, who was in her 80s, it was 81, told me that she had never breastfed her child, you know, and she had my mother in the 50s. She did not breastfeed her child because she was unaware of what her body was doing. She thought it was nasty, that the fact that her breasts were leaking and that she could not control it. And so quickly a doctor was like, hey, I can fix it. You're one and done type of thing. And because she didn't breastfeed, my mother didn't breastfeed. And when I decided to breastfeed, my family looked at me like I was crazy. They did not have very positive things to say to me about my choice with breastfeeding or even having a natural birth. And so for us, we're trying to be that generation that is reclaiming these practices, by encouraging more Black and Brown people of color to get in the field of birth working. So that way, that representation and the identity of what we do with our bodies is seen from a positive light and not negative. And really making sure that we close that gap, because representation matters. So when you don't see people like you in these spaces, you're not necessarily going to view this as something that you feel like is acceptable in your community, or that you can even go out here and do yourself with support. And so we want to change that. And so here are some of the community partners that we have worked with. We are getting ready to work with Duke on a high-risk centering project with doula support, with a Black provider, Dr. Saran Wheeler. We work with Hearts, which is a teen pregnancy adolescent program providing doula support. A bunch of different agencies in the area. And because it takes a village, you know, we are a volunteer-based organization. We are moms, we have children, we have multiple children. This work cannot be done by a sole individual. It takes a family, it takes a village to be able to do this. And we want to make sure that we support the model of each one, teach one. So the work that we do, we have a lot of times, you know, mothers coming through our programs to say, oh my gosh, this was life-changing. I want to become a doula, you know, and so that is the model that we're trying to set up for the people that we serve. And this is just a past highlight. Like I said, we are a new organization, but we have done a lot within the year of being open. So to your right, that is me in the tub with my last child, Amina. That birth was just super, super powerful. We did delayed cord clamping. Pretty much everything that I wanted to happen with that birth was able to happen. Because of COVID, we were doing a community baby shower last year, and then it became a giving closet because we had to cancel the baby shower because of COVID. So the blessing of that is that we've been able to serve so many families across the triangle since March of last year. And the picture below is our first client. That is me with one of our doulas, Layla. And to be in a room with another woman of color, supporting another woman of color was a powerful, powerful, powerful experience. We definitely felt our ancestors in that space, and we definitely felt like we were able to make that space very sacred for that mom. That mom did not get to have the dream vaginal birth that she wanted, but she had a very powerful birthing experience with love and support. And she is forever grateful for the love that we were able to provide for her during that day. And she's still in our virtual village that we have going on right now. And again, like I said before, breastfeeding is such a powerful thing. I'm clearly nursing a 3-year-old right now, but we are trying to reclaim that in our community with love and support. And so this is Our first year we did Black Breastfeeding Week. We hosted a photo shoot. We wanted to make sure that when we talk about body positivity, we're just not talking about displaying your body however you want, but just really like loving on yourself, loving on your kids, taking away the sexualization behind breastfeeding, because that is what we hear a lot in our community is like, why is that boy still on your breast? He's too big, or just very like derogatory and very negative things around breastfeeding. And so we just wanted to show that it's nothing but love. That's all we're trying to do, is to support and encourage more women to breastfeed, whether it is exclusively nursing or a pump. Our goal is however you get the milk out, it's your choice on how you want to feed your baby. We support you either way. But we know that breastfeeding is so powerful, right? And for people of color, particularly Black people, we've had a history of generations of Black women who weren't allowed to nurse their babies. They weren't allowed to get the most valuable nutrition from their bodies to their children. And those children were neglected. Some of them died, and that trauma trickled down generation after generation, and so we wanted to make sure that we reclaim that and we support our families in a way that they feel loved. But also, breastfeeding is not easy. So if it's a situation where our families aren't able to breastfeed, or if they're having difficulty, we're providing that peer support and that guidance for them. We're providing them with access to lactation support, because these services are not accessible. So that is our end game, is to make sure that all of our services are available to Black and Brown birthing people across all socioeconomic backgrounds, and to ensure that their families are happy and thriving. That's it.
Thank you so much. I am going to share my screen again, and we're going to start our Q&A section. So we have 2 pre-prepared questions that we're going to address, and these are things that Alexandria and I have thought about, and our panelists as well. But while we're going through these, I see some people are already sending their questions in the chat. Please keep doing that. We can't wait to take all of your questions. And we will moderate that, so you can either use the raise hand feature when we get to that section, or you can keep sending them in the chat. We'll make sure we get to you. So the first question, what are the leading causes of maternal mortality for Black women, and how does this differ from white women? We have here a slide that shows some of the leading causes, and I'm not going to read these all out. You guys can read them. But if either of our panelists or Alexandria would like to speak a little bit more to this question, that would be fantastic.
Yeah, so from my personal experience and what I've seen with my clients, typically preeclampsia is one of those diseases where you just don't know. Like you can have symptoms, but it's no direct symptoms to say that this is what it is until it happens. And what I try to do with my clients to make sure is that if you're feeling dizzy, if you are having any symptom that is not the norm, make an appointment. Right now, the way that COVID is set up, a lot of my clients aren't able to be seen in person. It's a lot of telehealth appointments. And we really have to make sure that when our clients are having any symptom in which they don't feel well, their blood pressure up or anything is like that, I'm quickly to say, if you can't get in with your provider, go to urgent care, because you just never know what could be that trigger that could evolve into something else. For me, it is better to know that it's nothing at all than versus to just ignore it and hope that it'll go away. And unfortunately, I'm seeing a lot of providers just tell my clients that, oh, that's normal, when a lot of times it's not normal. It's a red flag that there's something seriously wrong. Unfortunately, because doulas are not clinical, we cannot share the details of these things with our clients, which is why I always try to make sure that they know that, like, if you feel in your heart of hearts that you're not feeling well, go to urgent care. So that way you can at least be seen. Because COVID has just made everything so difficult that if you have never been, if this is your first time around as a first-time mama, you really don't know what's going on with your body, right? Compared to someone who's had a baby before and understands the changes that's happening with their body. But I've had clients who've only had 2 appointments the entire time because of COVID, because everything has moved to telehealth. So I think it's really important that we make sure that we advocate that they seek help as soon as possible.
Thank you for sharing, Maya. Yeah, I think when Ashley and I were, kind of getting ready for this panel conversation, we thought it was really important just to be able to provide some more background information. And so I would definitely encourage people, maybe you are somebody like me who has not given birth to a child, hopefully yet, but is curious about learning, what are those causes and those pre-existing conditions that you may have, or somebody that may have, to just get yourself educated, like what Maya was saying. So before you end up in that situation, you know how to be able to advocate for yourself.
Oh, I'm not sure what is going on with this picture, so please disregard this, but I can let Alexandria tackle this question too.
Yeah, so this question is, what can future physicians do to ensure that Black women are treated equally in the delivery room? And so in our research, these are a couple of things that we have found. So future providers, I'm not sure if you have any on the call today, but things to think about is providing patient-centered care, addressing any implicit bias that you may bring to your healthcare practices, addressing the social determinants of health, and then also participating in cultural competency and training. I think Arielle also shared some really great examples earlier when she was talking about her mom's experience in the hospital. Arielle, not sure if you want to share anything else about what medical providers can do in this situation.
I think you really just hit like a lot of the main points. I think it just really comes down to like, if you becoming aware of your biases, if you have them, and just really learning to listen, because it's easy to stereotype, or it's easy to say, oh, hey, this group of people seems to have such a low pain tolerance. Like, I don't want to give them this medication, or just like things like that. Just like learning not to generalize and kind of see people as individuals outside of their race.
Yeah, that's fantastic. So I'll move on to, this is our third and final prepared question. And like I said, I've seen a ton of questions in the chat. That's so awesome. Keep them coming and we'll get to them in just 1 second. But this last question we had here that we've already kind of thought about is, what can doulas and or the broader community do to help reduce the mortality rates of Black women? Maya, I'm sure this is something that you can speak to a little bit if you want to take it away.
Yes, I think doula support is definitely like number one on the list, but I think also people have to be very mindful to how policies in the communities in which they live impact the various social determinants of health. So as I mentioned before, Durham had a housing crisis in the beginning of 2020, but we still have a housing crisis because gentrification has completely made it impossible for people to have an affordable place to live. Those various social determinants of health, whether it be, housing, education, work, all of these stressors impact Black women greater than other groups, because we feel it as soon as we become adults and we get out of our homes and we're trying to live and thrive. We have to deal with that racism every day. That is a weathering process. And it's interesting because I've experienced it. And so as an adult, I can now look back at my mom's timeline when she was raising me and my brother to be like, oh my gosh, this is what she was going through. I could see it in her face. I could see why she was having certain health conditions along the way. And so I think it's really important from a community standpoint to be very mindful of the different policies that are coming down the pipeline, to see how those policies are going to impact the families who are already struggling with the worst health outcomes right now. So again, like the transportation issue, families who are in communities that have poor schools, all of these things contribute to the overall health of Black and brown mothers. And so we just need to be extremely mindful of that.
I think it's really good that you included all those different bullet points, because it just shows that there's so many different ways to help. And I think that there's no one way, like there's so many different little issues within this giant issue. And so like for me, I'm a stats major, so I know that there's a lot of like missing data, and sometimes the data isn't even correctly collected within the data set. So that's just like one example of a way to help. But I think just in general, just like being an advocate, speaking up and raising awareness and just trying to amplify those like voices that are commonly silenced. And yeah, so there are a lot of different ways to contribute.
Yeah, and I was going to say the data is one of the biggest piece that is missing, because particularly in our state, the data is only being collected on women with Medicaid. So when you think about women who don't have health insurance at all, or even women that have private insurance, as Arielle stated before, that women who are college educated are the ones that are dying the most. And a lot of those women have private health insurance. So it is, that data is like the missing piece right now, I think, to help people paint a better picture. For example, there was a family, a young lady that passed away last year due to childbirth in this community. When we inquired information about why she passed away, the review board said it would take 3 years for them to gather that information. It should not take 3 years to gather that information. So we just need to, you know, advocate and again, speak out as much as we can about these issues, so that way people can start addressing them from a policy standpoint.
Great. So thank you so much, everybody. We are going to go ahead and move into the Q&A portion. So I have a list of some of the questions that have been coming through the chat, and we'll go ahead and just kind of go through them in order. And if you're the person that asked the question, feel free to comment as we kind of go along here. So the first question that we'll start off with is, how can someone become a volunteer doula with your organization, Maya?
If they visit the website, www.maaameinc.com, and I'll post it in the chat, there is a Get Involved section on our website, and they can register there.
Great, thank you. Okay, so another question that we've gotten here is, how can community providers who are not involved in healthcare field connect clients to the work that doulas are doing?
There are several community advisory boards. I don't know where everyone lives, but I would definitely check with your local health department to see which boards are tackling issues around maternal health. So in Durham, there's the Born in Durham Healthy for Life with the health department. There's a mix of providers and doulas working on that board. And that's a great way to share resources. Also, any of the early childhood education groups, advisory groups, will be a good way to connect with birth workers as well.
Great. Another question here. How can Black women be preventative in preparing our bodies for health conception?
I think we have to have conversations early and embrace it's kind of nice, the good way to say this. I think sometimes we are so reliant, we've been taught to be so reliant on the medical institution to provide the type of care for us, that we have lost what agency looks like in ourselves. And so I think, you know, as a community, we have to have some deeper conversations to kind of remove some of these barriers and negative perspectives that were taught to us, so that way we can start early prevention.
Fantastic. Thank you. I do think that's really important. So for Maya, another question here. How have you found that doulas are open or not open to working with, or doulas and doctors? How's that relationship work? Doctors open to working with doulas? How do you go about fostering that positive relationship?
I think it is mixed. I've been in situations where I've probably had better relationships with providers than some of my peers. And I don't know if it's because I have put myself in those spaces, and I know not everybody necessarily has access to those spaces. I think my situation is a little bit different. I've built relationships with providers that I've trusted, and because of that, they were then refer me to another provider and another provider and another provider. Not everyone has access to be able to do that. I've come across some providers who were just very rude, whose bias and racism was showing in front of me, in front of my client. And then again, like I said, I've had some very powerful experiences where the provider trusted me to be the expert in the room, and because of that, I was able to help communicate what they were trying to communicate to my client that wasn't coming through on their end. And so I feel like if providers can work on establishing relationships with doulas, they can definitely see better health outcomes, because at the end of the day, we're the ones that's in the room the entire time while that person is laboring. I've had 3 births back to back within the past week, and I've spent 2.5 days in the hospital, with that client. Going through explaining all of the procedures, all of the medicine, making sure that client fully understands what their choice is in this situation. Whereas the provider may be there only for 24 hours and gone, within the next shift. And then there's a whole new person that client has to now learn while they're there laboring. So I feel like it's really important for providers to kind of step out and get to know people within the birth working community, so that way we can have a stronger birth team in the room for their patients.
Thank you. We just had a question come through that I'm going to pass over to Arielle. So what can I say to a provider, a healthcare provider, when I see implicit or explicit bias towards a client?
Definitely. Well, you could either try to, I guess, maybe confront them or just talk about it. I mean, you don't have to be like super aggressive. I mean, you can, but at least just let them know, like, okay, what you're doing maybe might be a little wrong, and kind of ask them to think about where it's coming from or why they might be thinking what they're thinking. But definitely just at least like pointing it out when it happens, because if you don't say anything, these things can just like continue and people think it's okay and it's not.
Yeah, I know that that's a hard conversation to have with anyone, regardless of the situation. They have now simulators where you can go through and kind of have these conversations. I know one is like, you noticed your boss committing some microaggressions, things like that. They have these tools online where you can go through and practice having these conversations, so that if and when the time arises for you to have that conversation in real life, you're already prepared with tools of like what specific sentences you can say, what kind of, language is most effective to convey that tough conversation.
I would also say, if you're having that conversation, have that conversation outside the room. I never like to speak with the provider in front of my client, because I don't want to shift that energy to further stress them out while they're in their birthing space. And a lot of times when you step out the room, it's just you and the provider. It creates an opportunity where you can actually engage, even if it's going to be a tough conversation. You can still engage in a way that is not going to put that stress on the client. And if you feel like that you're not being heard or respected, even as a caretaker for that client, then there are other patient advocates and other steps that you can take in the hospital to address that issue without overwhelming your client in that space.
Thank you, everybody. Another really interesting question here. What processes do you have in place to help an HIV positive person on their birthing journey?
So we personally don't have a process, because we serve everybody. I would not treat them any different. from any other birthing person in that space. The training that I've gone through is the same training that someone who works in the hospital would have to go through, the same procedures with blood pathogens and things of that nature. So they would still be given the same level of treatment and care and respect, and any information that I would provide to a person that doesn't have HIV and AIDS would be given the same information.
Fantastic. So this is kind of circling back to, excuse me, earlier in your presentation, Maya. Can you talk a little bit more about some of the benefits for breastfeeding, as well as breast milk banks that might be available for women who are not able to lactate?
So breast milk is such a powerful resource that we naturally make as birthing people. It's all of the vitamins and the antibiotics that are there are some of the most powerful nutrients that you can give within the first couple of hours of birth. Unfortunately, there are not a lot of accessible breast milk banks, not in this area. A lot of times they are especially for NICU patients. And so that is the downside of, at least in North Carolina. Again, I don't know where everyone else is, but it does become an issue for families who are struggling with breastfeeding to find donor milk. There is a big community of women online who are sharing milk with each other at their own risk, because they know how important it is to have breast milk. But I would definitely try to contact your local hospital to see what their policies and procedures are with getting milk to non-patients, because you might be able to find a safe way to get milk to nurse your baby. Or again, you can contact maybe one of the birthing centers where you might be able to find a safe way to get milk.
Great. So we are gonna close with one more question here. Do you feel that virtual doula services have the potential to impact perinatal inequities?
I do. I feel like we're able to reach more people now virtually. I know a lot of people enjoy the in-person support that they get, but when COVID hit, we were getting phone calls from people who were living in California because they had a loved one here that they couldn't get access to because they weren't able to get support in the birthing space that they were having a baby. We're able to serve more people outside of our own local area now in more rural parts of North Carolina because of telehealth. It does have its challenges, but I think the ability to know that you have someone that you can call on, you know, that you can text and get whatever information, evidence-based information from a trusted source. I feel like that is a big mood buster. I mean, a mood lifter. For example, I've had a client who had high blood pressure the entire time out of her pregnancy during COVID. And so she would call me when she would get to the doctor's office. I said, get there 30 minutes early, sit in a car and just breathe. Don't think about anything else. Don't worry about what's going to happen when you get through the room, and just breathe. And that little change that she would do would significantly decrease her blood pressure levels when she would go into the hospital. Because when she was at home, her blood pressure was not the hospital, the doctor's office. When she was at home, her blood pressure was fine. But as soon as she entered to her provider's office, it went right on up, you know, and she was able to have a happy vaginal birth with little to no intervention as a high-risk mom. So there are a lot of ways that virtual work can create successful birth outcomes.
Thank you so much for sharing. So if you're sitting here and your question didn't get answered today, don't worry. We're going to be writing a blog, kind of recapping this event, and usually in the blog, we try to address any questions that we didn't get to. So right now I'm going to screen share just some of our final closing slides. We do have some additional resources here that you can check out. I would definitely recommend screenshotting this slide. As you can see, there's books, things you can listen to, accounts to follow, and then of course, Maya's organization, the website. So also, I'll leave this up here for a minute for you to screenshot. Just want to mention a couple things. Like I said, we'll have the blog coming out that will probably address any questions that didn't get answered. We're also going to send you all an email after this event is over that will have a brief survey about the event. If you don't mind filling that out, that's a huge help to us, and it can make our next event even better. It will also have some additional resources, things for you to look at, things like that. We're also going to be posting a recording of this conversation to YouTube. So if you want to go back and reference maybe something one of our presenters mentioned, that will be available to you as well. And I just want to throw out there to save the date. So this Tuesday, we're going to be having a screening of the Invisible Organ documentary, which deals with cervical cancer and some of the inequities surrounding women's health and cervical cancer. And then that will be followed by a conversation about sexual health. This is open to all undergraduate students, whether you're from Duke or not. So please feel free to share this with any undergrads. If you're a faculty member, share it with your classes. The link to RSVP and attend this will be in the email that we send out to you after the event. So don't worry about that, we will send it to you. And then lastly, we just want to say thank you so much for coming on behalf of GWHT and our presenters. It means a lot to have you here. We're so excited that we got to have this conversation today. Please feel free to reach out to GWHT if you have any further questions. We can connect you with our panelists or with any other resources you might need. So thank you guys so much.
Thank you.
Yeah.
Thank you.
Thank you.